My name is Edel Burton. I'm a pharmacist and PhD scholar at University College Cork. And the title of our study is Appropriate Prescribing in Hospitalised Older Adults with Renal Impairment, a retrospective audit from the Senator trial. Potentially inappropriate prescribing in renal impairment can cause adverse drug reactions. And if we look to the literature in terms of prevalence of potentially inappropriate prescribing in this cohort of patients, we see that one study conducted in the UK showed that 24% of hospitalised older adults with moderate to severe renal impairment were discharged with at least one potentially inappropriate medication. If we go on further, you'll see from the literature that acute kidney injuries are seen in 13 to 18% of all people admitted to hospital. And older adults are particularly susceptible to these AKIs. Lastly, medications can be implicated in between 20 to 66% of acute kidney injuries in this older cohort of patients. So what is the Senator intervention? Senator was a computerized intervention, and it was aimed to optimize pharmacological therapy for multimorbid older adults, so adults that were 65 years or older, and these were in hospital, so hospitalized adults. This intervention was based off the stop-start criteria and also drug interactions. So what I said previously is that we know that potentially inappropriate prescribing in those with renal impairment can lead to adverse drug reactions. But the Senator software algorithm was not originally designed to review medication appropriateness based on this criteria. Thus, the rationale for our study was that we discovered that 25% of the Senator participants in the Cork trial site had an acute kidney injury on admission to hospital or around the time of recruitment to this study. However, we were unaware before conducting this study of the prevalence of potentially inappropriate medication based on renal function in this cohort of patients. So our study aimed to then look and investigate the appropriateness of prescribing for medications that require either dose or frequency adjustment based on renal function in these older adults in the Cork site of the Senator trial. In terms of methods, carried out 4 main steps. Patients with an estimated glomerular filtration rate of less than 90 mils per minute per 1.73 meters squared were eligible for inclusion in the study. Then those medications which require dose or frequency adjustment in renal impairment were assigned an anatomical therapeutic chemical code, or an ATC code. These medication regimes were then compared to BNF recommendations for dose adjustment in renal impairment. And SPSS was used to carry out both descriptive and chi-squared statistics on the data. We used the BNF as our reference text in this study, as it quoted renal function using estimated glomerular filtration rate. The Senator database only gives us renal function in modified diet in renal disease, only in that form. So we couldn't use texts like the Renal Drug Handbook or some summary product characteristics, as they only quote renal function in creatinine clearance, and we did not have the data to convert one measurement to the other. Thus, this could potentially be seen as a limitation to the study, along with the fact that the study was only conducted in one study site. So in terms of results, I want to firstly draw your attention to the fact that of the 406 patients in the Cork trial site, 313 had an eGFR which made them allowed to qualify for this study, so an eGFR of less than 90. 53% of our study participants were male, the mean age was 78 years, and the range was 65 to 93. Of the 2,115 medications which were prescribed to these patients, approximately 7.8% of them were potentially inappropriate. The mean number of medications prescribed to these patients was 10.7, and this includes both regular medications and as required medications. In terms of non-adherence to BNF recommendations, 35.8% of patients in the study had at least one non-adherent medication, 7.32% had at least two non-adherent meds, and 5.1% of patients had at least three non-adherent medications to BNF guidelines. That means that the prevalence of potentially inappropriate medications was over 30% in total. And this is seen as much higher in the literature, which oscillates from between 12 to 24%. I mentioned previously that we carried out chi-squared statistics on the data. So we did see if there was any differences in the number of PIMs based on sex, age range, or number of medication, but there was no statistically significant difference found. You'll see here the top 5 drug classes which were non-adherent to BNF recommendations in our study. And the first one was joint first is antimicrobial drugs and antithrombotic drugs. The antimicrobial drugs being the class with the highest number of PIMs is consistent with the literature. However, antithrombotic drugs being in this top 5 is not necessarily consistent, which is what has been studied previously. Then we also included the top 10 medications. So we broke down the classes into these medications which were non-adherent to BNF recommendations. And I'll draw your attention in particular to the tinzaparin, because this would only have been prescribed in hospital for VTE prophylaxis. So it could be possibly inferred that the prescriber didn't consider renal impairment when they were prescribing this particular medication. So in terms of the acute kidney injuries, there was 14 incident in hospital acute kidney injuries out of these patients in our study. 8 of these were caused by medications. And of those 8, 4 were caused by medications that were non-adherent to BNF guidelines. Thus, these possibly could have been prevented and mitigated at the time of admission. So as I previously showed the 5 top non-adherent drug classes in our study, and I mentioned the antibacterial drugs are the top class in our study and in this study of Jones et al., which does reflect the literature in this area. You can see that 3 out of 5 of the classes do totally match, but that one class in particular, as I mentioned, the antithrombotic drugs aren't actually mentioned in a lot of the literature. So our study has shown 2 main things. It showed the possibility of preventing in-hospital adverse drug reactions if they're identified at admission. Secondly, there is limited evidence showing computer-generated recommendations can improve clinical outcomes, like the reduction of AKIs or other adverse drug reactions. So in conclusion, we've concluded 3 main things. Over 30% of the older adults in this study had at least one medication non-adherent to BNF guidelines. Secondly, that our study emphasizes the importance of constantly reviewing medications affected by renal function in older adults throughout the entire hospital admission, and also intervening where it's deemed appropriate. Finally, that possibly recommendations based on renal function could be included in the algorithm for future computerized interventions. And all of these will hopefully improve patient outcomes and prevent medication-related harm in the hospitalized multimorbid older adult.